So before we demonstrate the side-lying rotatory thrust technique, it's helpful to just go over a quick background and also show you on a skeleton what is happening in the spine when you do the technique, where you're trying to place your hand to give you a good visual to help your setup when you're doing the technique. So I think the first thing to note is that this is kind of a blend between specificity and non-specificity. And what I mean by that is if somebody had pain in their back and it was primarily coming from, say, the L3, L4 segment, then you would want to try to isolate your forces to make sure that you are getting that segment to move. So you want enough specificity where you can say, my technique is going to affect that segment. But the non-specificity side would say that if you perform the technique and there's multiple cavitations heard, you're probably moving things outside of just that L3, L4 segment. So traditionally, this side-lying rotatory thrust technique, the clinician would attempt to lock out the vertebrae below, lock out the vertebrae above, and then put their hands only on the vertebrae that they're trying to move and create a thrust right at that one segment. The problem with that is it probably requires more force and leverage to create enough movement in the spine to ensure that you get the motion that you want to get at your target segment. And if you do that and you hear those multiple cavitations, then that's the non-specific part of the technique. So when you look at the skeleton, you'll see that where you're placing your hand. Prior to the technique, you want to have an idea about what segment you're trying to target, and you can do that through your other examination techniques and get an idea about where you think that needs to be applied. So we'll show you on the skeleton what you're kind of looking for, and then we'll demonstrate the technique. Okay, so here we got a close-up of the lumbar spine, and let's say we go back to that L3, L4 segment right here. So when the patient is side-lying, if their right side is the side they're laying down on, the left side is facing up, then what you're going to do is L3, L4 segment, you're going to find the inner spinous space. So right here, that's where you're thinking approximately 2 finger widths lateral to that inner spinous space is going to place you over the mammillary process. So the mammillary process of L4, so the inferior vertebrae, L3, L4, the inferior vertebrae, that mammillary process, ideally, that's where you would put your hypothenar eminence, right over that spot. You could even think about maybe your pisiform is going to go right there. But you're going to apply that hypothenar right over that spot. So that, transverse process, mammillary process, but that's where you want to be able to place your hand. So that way when the trunk rotates, if I have my force hand right here, and then I've got their trunk rotated, which you'll see when we demonstrate the technique, you're going to get a gapping of that facet joint right there. So your hand blocks here, and then, so the thrust is by pressing and creating this quick motion of rotation. So you can see that, yes, you might be gapping multiple segments when you do that, but you are going to target that particular segment when you do that. So now let's demonstrate the technique. So to perform this technique, the patient will be in side-lying, and they need to be scooted towards the clinician close enough to approximately 2 fists, their abdomen approximately 2 fists from the edge of the table. You can adjust that a little bit, but you'll see why here in a moment. So the second thing is the table height is going to be approximately at the level of your own VMO. You need to be able to have the table low enough so that you're able to get your body or the patient underneath your body, because you're going to be using a vertical body drop to perform the thrust part of the technique. The table height needs to be pretty low. So it would be assumed that you kind of a predetermined segment that you're going to try to focus on targeting. But this is a fairly non-specific lumbar rotation thrust manipulation technique. So you are going to use your hypothenar eminence to try to isolate a particular segment, but also knowing that it's difficult to just get one segment to move. So you would have already kind of had the idea if you want to try to target the L3 or 4 segment or L4 or 5 segment, you would have already kind of had that predetermined, and then you would need to use your hypothenar. So if you were going to be targeting the L3, 4 segment, for example, you would be putting your hypothenar eminence on the facet joint or the mammillary process of L4. So you're trying to gap the facet joint between L3 and L4. So to do that, your hand placement would need to be approximately 2 finger widths lateral to the inner spinous space. So if I was, say, if that was L3, L4, inner space, I'm going to be approximately 2 finger widths lateral to that, directly lateral to that. So my hypothenar would be placed here. And it's good to take up a little tissue slack, but you can see where there's going to be some non-specificity with this. So that's going to be kind of thinking about what your hand placement's going to do. Now, the patient's top leg, you're going to flex the hip so their foot can be behind the popliteal space. I'm going to extend the bottom leg. I like to have the bottom leg kind of off the edge of the table, kind of creates a little bit of stability on the bottom leg, like so. Now the trunk, we need to lock out the trunk, the thoracic spine. So to do that, we're going to take the patient's bottom arm, and then I'm going to go underneath the arm and create a scoop. So this hand's going to go on the scapula, this one's on the arm, and it's not a pure rotation. There's going to be a flexion component to this. So it's a flexion rotation. So that way you're avoiding just excessive amounts of rotation of the spine. You're getting some flexion and rotation here. Now, sometimes people will also too rotate the pelvis, pre-rotate the pelvis a little bit too, in that same, kind of rotation pre-position. This hand will just be on the rib cage. This hand's going to be behind their head, like that. Now, you're going to have your hand on their shoulder. If their shoulder was a problem, you could take both hands on the rib cage and do this instead. But you're going to get more leverage if you are able to use your hand on the shoulder. So at this point, you're not going on top of the patient, you're bringing the patient underneath you. So you're rotating them underneath you, like this, opposed to trying to come on top of the patient. So it's thigh-to-thigh contact. I'm going to get my ASIS as I rotate them underneath me. I'm getting, again, thigh-to-thigh contact right here. And then this is where the hypothenar comes into play, like we were mentioning earlier. You're at the inner spinous space, approximately 2 finger widths lateral. I'm going to take up a little bit of tissue, fascial slack here. And now my fingers are facing superior, like this. So this is where we would roll underneath me, like so. And then it's primarily a body drop, secondarily pressure through my arm. So most of your force is going to come from your body dropping weight down. You doing okay? Mm-hmm. Yeah. Kind of get some of a few practice maneuvers before the body drop. Now, quick note on the body drop is I am in a staggered stance where my weight is on this front leg. You can't see very well from here, but my back leg, my heel is off of the ground. So I'm in this position here, knees bent, all my weight's on that front leg. So that way when I drop weight, I'm bending this knee quickly, and then my heel drops to the floor on my back leg, like that. That's the action you're trying to go for to get the vertical body drop. Doing okay in that position? Mm-hmm. Like that.